Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the last week of August and starting into September, and globally, as you all know, the numbers continue to rise exponentially. There are a total of 217,408,000 plus total cases globally, 4.5 million deaths so far. In the United States, our total numbers are over 39.1 million, with almost 640,000 deaths as of the time I'm recording this. In the last 28 days, those numbers are even worse sounding, 3.9 million new cases in the last 28 days, with almost 25,000 deaths. So although the deaths are certainly significant, there are a slightly fewer number in many parts of the country, with some parts of the country, notably Florida and other parts of the Southeast, that are experiencing overwhelming burdens on their healthcare systems. And once again, the grim stories of running out of space to put both patients as well as those who are deceased. In pediatrics, the report from the American Academy of Pediatrics from August 26th, total cases are almost 4.8 million cases in children, which is 14.8% of the total, and that comes out to just over 6,300 cases per 100,000 pediatric patients. Once again, looking though at the last week, it's much more ominous. In the last week alone, children up to age 18 have accounted for 22.4% of the total new cases of COVID-19 in the United States. That is as high, if not higher, than it was during the winter peak. So if anybody's looking for proof, I guess, that the Delta variant is affecting pediatric patients much more significantly, there it is. It's right there. Tons of kids are both symptomatically sick and being evaluated and being hospitalized, and unfortunately are going to start dying. In Arizona, our total cases from the start of the pandemic, 176,354 pediatric patients of birth through 19. That is 17.7% of the total cases. That's cumulative. And again, looking the last week, it's much higher than that. In fact, reports from Maricopa County, for those of you practicing and or in catchment areas, including Maricopa County, it's 25%. 1 in 4 new cases of COVID-19 is in a pediatric patient. Our rates per 100,000 are 9,592. That's the highest it's been in Arizona, although, believe it or not, we are not the highest or the worst in the country. In terms of caseload per 100,000, we're down at number 6 or number 7. And again, being eclipsed by states in the Southeast. So this is not insignificant, folks, and again, this is obviously not news to anybody. A lot of the questions are knowing all this, what else can we be doing, and what else can we anticipate in terms of help for preventative measures, and also what can we be doing to advocate for limiting spread in the school setting, which of course is a huge concern. Talking points are available. I think many of us are participating in activism, advocacy, outreach, etc., taking fire at school boards from the general public, certainly advocating online via webcast, etc., to suggest to the very, very virulently vocal minority, as well as to the governor and the state legislature, that indeed Delta variant is a new game here. It is affecting children through adolescence much more significantly than it has before, and it is affecting them in a way where they are becoming just as contagious as we have experienced previously with the flu. So absolutely, the reality is that there are school-associated clusters, epidemiologic clusters. It's kind of hard to keep track, and the health departments are doing an admirable job of trying to do contacts investigations, but they're overwhelmed, overburdened. So estimates are hundreds upon hundreds of individual clusters of local epi outbreaks related to school and school activities, especially in those schools that are not yet advocating for mask mandates. Just a couple questions and then a couple additional topics to talk about with you all this week. First, my thoughts on the combination of flu vaccine, the annual flu vaccine, and the possibility of a combination product with COVID-19 vaccines. Well, boy, it's a great question. It's a very timely question, obviously, because we are now already anticipating the start of flu season. Nobody honestly knows how to predict how good or actually how bad this year's flu season will be, given that we all know we're right smack in the middle of winter and summer in terms of RSV, rhinovirus, enterovirus, parainfluenza, adenovirus, and yes, indeed, some sporadic cases of influenza. We're already seeing those. And so, certainly, as we previously came out from behind the masks and exposed ourselves and our children exposed themselves to respiratory viruses, the numbers are just as bad as any of us has seen in the wintertime, except here it is end of August, early September. That being said, it is entirely likely that we can anticipate a bad flu season, but all bets are off. Who knows what is affecting the natural reservoirs of influenza in terms of an anticipated outbreak. It is interesting that the other hemisphere where we typically look to see flu history or flu exposure is not experiencing a huge number of flu cases, but our reporting countries, Australia and New Zealand, for example, are still doing an incredibly good job of mask mandate, social distancing, and limiting their COVID numbers. So I think it's probably not wise to look at other parts of the world to predict how flu is going to be for us. So all that said, this is an incredibly valid question. What do we know? There are experiments and population studies ongoing, not in the States, but in other parts of the world, looking at a combination COVID-19 and influenza vaccine. The data so far is good, that there is good seroprotective response to both vaccines when given in combination as a single product against both SARS-CoV-2 and influenza A/B. But those vaccine trials are not occurring in the States. And keep in mind, we're still working on getting vaccine approval, either by emergency use authorization or formal approval for children in many cases. So we're nowhere near a combination product for pediatrics. And again, the studies are not being done in any large study population in the States for adults. So fingers crossed, keep your hopes overt that such studies will occur, just not quite yet. All that said, however, there have been safety studies and outcome studies and efficacy studies looking at the vaccination of both a COVID-19 vaccine product, whether it's an mRNA or one of the adenoviral vectored products, and other vaccines, including influenza. So two separate vaccines given same time, same visit, different sites. So perhaps opposite deltoids, for example. And there, the outlook is excellent. There has been strong protective efficacy of both vaccines, one given same visit in opposite sides of the body. So that I think is quite reasonable and certainly something we should look forward to into our own practices as we recruit patients, hopefully coming in for routine visits, preventative healthcare visits, and getting caught up on all those other routine vaccines. We should be able to, when we're able to, age-wise, vaccinate with those vaccines, including the flu and COVID-19. So doing both together, same visit, absolutely yes. Go for it. CDC is on board. ACIP is on board. Go for it. So a related question then is, where are we at with COVID-19 vaccines for kids, period? I think we all saw that the FDA, with backing from several different national organizations, gave formal approval of the Pfizer mRNA vaccine for ages 16 and up. That was the original emergency use authorization. They went through the processes. The data was good. Everybody signed off on that. So age 16 and up has formal approval for a COVID-19 vaccine from Pfizer. Moderna is in the process of submitting its application for formal approval. This will be for age 18 and up to the FDA, and anticipates having its process completed not in the 3 or 4 weeks that I was hoping for, but actually in the next 2 to 3, maybe even 4 months. So it's going to be a while before Moderna gets on board with a formal approval. But at least we have one, and hopefully that'll start to reassure our older adolescent and young adult patients, if we have those, that indeed the vaccine has formal approval and therefore hopefully is attestably safe. It has been, we know this, but this is, I think, a good talking point for those individuals who have vaccine hesitancy concerns due to being a temporary approval only. So great, wonderful, fantastic. Emergency use authorization still exists also for the Pfizer vaccine for ages 12 years and up. And the process is ongoing to eventually achieve formal approval for that. Keep in mind that there's not only a 6-month data collection period requirement for formal approval of any medical intervention, such as a vaccine, but also a process which must be observed. So it's going to take a while there. That said, also, there is incredible national pressure from every organization, including the American Academy of Pediatrics and others, to the ACIP and to the FDA, and also, I guess by extension, the CDC and Human Health Services, HHS, to get off the seat and get going with the approval, formal approval, or to at least emergency use authorization for kids younger than age 12. I'm of two minds about that. Yes, absolutely, there's urgency to get our younger kids vaccinated because Arizona, at least, is in school. We're seeing the outbreaks. Kids age 5 and up are being infected, and they're taking it to their parents, who are taking it to their coworkers. And so, Arizona is rapidly rising, and I think, unfortunately, kids are a major part of that epidemiologic surge. So there's huge need to vaccinate kids as young as possible, as soon as possible. But we need to balance that incredible need and pressure with the fact that we need to still do due process to evaluate and confirm safety. Not that I have any personal or professional concerns for the safety of either of the mRNA vaccine products in children, but we have to note that the myocarditis association was unexpected and appears to be, not appears, it is real, in association with the Pfizer and Moderna mRNA vaccines for kids ages 12 and up. Who knows what potential risks might emerge as we do population studies and as we, in fact, start vaccinating kids ages 5 through 11 or even younger. I, for one, would not appreciate the multiple screaming questions about why didn't you do due process to protect our kids and just gave them this unsafe product. You can imagine how those conversations are going to go, right? So I do feel that due process needs to be observed and that reasonable caution needs to be observed as well. That said, I would hope, and I think all of us can advocate, that individuals who are at the pharmaceutical level and the approval level are not sitting on their thumbs thinking that they have all the time in the world. They do not. This is a battle zone and we are losing hard. So absolutely, if the questions come up and if any of us have the ability to advocate at a regional or federal level and lobbying effectively to push the process as quickly as is safely expedient, then do it. We've got to do it. Okay. All right. The other question which we received since the last podcast is to please elaborate on the risk of the Lambda variant. Yes, currently the United States of America is overwhelmed by the Delta variant. It is well over mid-90s, probably 95, 96% of all our new cases having eclipsed the Alpha variant, which in its turn had eclipsed the prior D614G variants. So Delta is our bane right now. But Lambda is still out there. For those who were not, I think, able to listen to the last podcast, Lambda variant initially was described actually over a year ago in Peru and sort of was a quiescent, like kind of nasty, but not doing a whole awful lot. And Peru itself was having significant challenges with its healthcare infrastructure and therefore has been and was and probably still will be overburdened by new cases, an increasing percentage of which are caused by the Lambda variant. The concerns and the reason why this is an important question are that Lambda variant seems to fly under the wire and has been sneaky in causing increasing numbers in surrounding countries also in South America. So it's not just Peru anymore. It is now also Chile, in which 56 to 60% of their new cases are Lambda variant, also being demonstrated in Argentina, Colombia, other parts of South America. Unfortunately, those countries in that part of the world in South America has as its primary vaccine a product from China, the Sinovac vaccine, which is a good vaccine, but it appears not to have the demonstrated efficacy against Lambda variant that we currently enjoy with our vaccines against the Delta variant. The Lambda variant has not been tested extensively in the setting of our two current mRNA vaccines or against the Johnson & Johnson vaccine. So we really don't know how the behavior of the Lambda variant might be should it gain a further toehold in this country, and in fact how concerned we should be. But at least looking at epidemiologic history in South America, the concern is real. Where are we at right now in the States? There are sporadic cases of the Lambda variant, a handful here, a couple, 10 or 20 there. So it is not a huge impact so far, but that also is, or at least was, the pattern in Peru until things increased significantly. So that's where we stand. Don't know a whole awful lot about it other than the fact that it has potential to emerge into a vacuum if and or when we do a better job of getting on top of the Delta variant. I think, as you all imagine, we're behind the eight ball on that one in terms of getting our 100 million plus Americans who are vaccine hesitant to get vaccinated. There have been a whole bunch of, pardon the phrase, but foxhole converts, meaning under fire, got COVID, wish I got the vaccine, and now getting vaccinated. And I hope that'll increase our numbers significantly. But this virus is mutating rapidly, folks. This is no big surprise. It is no surprise whatsoever that Delta variant is kicking the world in the teeth right now because we were unable to get the virus under control with prior vaccination efforts, and lo and behold, mutations occurred. So too with the Lambda variant. We will see other variants for sure. We're not done with this yet. So I think stay tuned for the next round, which will occur, not might, but will occur, and it may be caused by the Lambda variant. Okay, some additional issues just to touch on. Where are we at in terms of timing for vaccine indications for the younger age population? I've already mentioned that Moderna is still working on data for the age 12 through 17. It does not yet have emergency use authorization, but it's coming hopefully soon. But luckily, we already have a successful product with the Pfizer vaccine. And then the younger ages, as noted before, data collection, patient recruitment into the studies is ongoing. But the numbers required, I should say, by the FDA have doubled to try and do a better job of statistically picking up any risks with such complications as myocarditis or other hyperimmune reactions. So because those numbers have been increased and the vaccine sites are still rapidly recruiting patients, the anticipated release date for emergency use authorization is now being given as midwinter. So midwinter for a pediatric indication ages 5 and up for the Pfizer vaccine, maybe hopefully also for the Moderna as well, but not until sometime around November or December. Boy, booster shots, third vaccines. Once again, the current official recommendation by CDC is that patients who are immunosuppressed or immunocompromised, and there's very liberal definitions of who those people are the currently approved patient population for booster vaccines with either a Pfizer or Moderna, if depending on which series the patients initially got. Johnson & Johnson's vaccine, the Janssen pharmaceutical, has also released very strong data giving a second shot. Keep in mind, Johnson & Johnson's vaccine is a single-shot series, which has been in the mid-60s% effective against the Delta variant and other variants of SARS coronavirus 2. However, J&J just released new data with a second dose showing a significant boost, a significant increase in antibody protection against all the currently circulating variants. Again, not so much the Lambda, but at least the Delta variant. And so look to see J&J's vaccine also included in an additional dose or a booster dose for individuals when that indication comes. So right now, individuals for whom formal approval and or emergency use authorization currently exists, i.e. ages 12 years and up, who also have some degree of immunosuppression, which could be as little as chronic steroid use, could be an individual with a rheumatologic disease who is managed with biologics, certainly includes patients with cancer, both actively on chemotherapy and also potentially in remission, absolutely transplant recipients, solid organ and or bone marrow. Basically, if somebody has a disease in which they're receiving a chronic immunosuppressive medication and or might receive a chronic immunosuppressive medication, those are individuals who can receive a booster right now today, assuming their age is 12 and up. How about the rest of us? When is it coming? CDC, FDA, ACIP, the feds, etc., are all suggesting that the formal approval for booster shots for the rest of us will come through in mid-September. So actually, potentially around the time of the next podcast, I will hopefully have more information to share with you. But as it is right now, of course, we all know individuals, patients, the general population, maybe even our friends, colleagues, and ourselves, not me, have rushed out to get a booster dose, sort of telling the little white lie that perhaps this is their first dose period. Obviously, I do not support that. That is dangerous in terms of violating emergency use authorization for our pediatric patients. So absolutely, please do not consider that unless the patients meet criteria. For the rest of us, sit tight for just another couple weeks, and then a booster dose is going to be formally approved and offered through the feds. Is it a good idea? And here I think is boy, I'm of two minds. Yes, the current two-dose vaccine series for the mRNA vaccines that most of us received, and the single-dose series from the J&J vaccine are protective, do have the ability to provide long-lasting protection against even the Delta variant. And I would not wish to be heard or seen or appreciated as recommending a booster dose in any way suggesting the vaccines are failing. That is not true. That said, there is excellent evidence that a booster dose given anywhere from 6 to 8 months after the second dose of an mRNA vaccine or after a single dose of the J&J vaccine has the ability to cause a significant increase in antibody seroprotection, recruitment of cell-based immunity, and absolutely a delivery or in recruitment of neutralizing antibodies. Far more so than might be expected with an annual vaccine. So there is already a suggestion that booster doses, when they are approved, may actually allow the recipient to forego the current fears of an annual COVID-19 vaccine, assuming, of course, that not too much changes significantly with new variants and etc. So scientifically, based on the immunology of the vaccines, I understand and I agree with and I support the use of a booster dose. I myself am waiting for the Maternal trial that I'm still a part of to consider if and or when it'll be doing booster doses for its study participants. For the rest of you who have the ability to go out and get booster doses when they're approved, I would support that. I certainly support that for our pediatric patients who are currently falling under a vaccine approval by emergency use authorization. So it's coming soon. I do think it's a good idea. It'll be interesting to see, again, in large population studies, how effective the booster doses will be in limiting breakthrough cases. I would suspect that there will be a significant impact on those. It will also be interesting to see, and again, this is going to depend on large population studies, what the impact of a booster dose will be on contagiousness. We all know, because we've seen the data, but I'll mention it here again, that vaccinated individuals who have a breakthrough case and or are exposed, infected with, you could say, SARS coronavirus 2, have similar viral loads detected in their nasopharynges to those who are unvaccinated, meaning that we could potentially be just as contagious should we be exposed, infected with an asymptomatic breakthrough case as somebody who's not vaccinated, and that poses real risk to our patients, our families, etc., and so forth. My suspicion is the booster dose is going to increase seroprotection to the point where that that phenomenon will also go away and will reduce the contagiousness or infectivity of vaccine recipients should they have a significant exposure. Fingers crossed that's what's going to happen. So, as I just look over the list of questions, I think that covers all of them. As always, thank you for listening to ID Talk. AzAAP members can submit questions for future episodes to covid@azaap.org. The AzAAP, if I could speak properly, would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Keep those questions coming, folks. Keep the heads above water. We've got this. We just got to keep plugging away. Thank you all.